morning. Today we are going to be doing the assessment of the central nervous system. Before we start, I want to introduce some of our equipment. So we have the otoscope, the ophthalmoscope, the tuning fork, the reflex hammer, the earpieces for the otoscope, a tongue depressor, and something that is dull and sharp and light for certain assessment. Okay? And we also have something for the patient to smell. Right? Good morning, sir.
Good morning.
I am Nurse Sant. Can you tell me your name, please?
Steve Bartholomew.
Okay, Mr. Bartholomew. Today I would like to do an assessment, also known as an examination, of your central nervous system. This will involve me looking at you, touching you, asking you to follow some simple instructions. Your privacy will be maintained throughout. Any information that is gathered here today will only be passed on to your healthcare provider if necessary. If any time during the examination you feel uncomfortable in any way, please let me know and we will try to adjust until you're happy. Do I have your permission?
Definitely.
Okay. Thank you very much. So you don't need to be in a gown for this situation. Alright? So we won't ask you to do that. I have screened the area and we're ready to go. Okay? So the first thing, sir, is we are doing your cranial nerves. You have 12 cranial nerves and we have tests that we'll be doing for each of them. The first test is cranial nerve number 1, the olfactory nerve, where we are going to test your sense of smell. Right? So, sir, what I would have to do is I would have to ask you to close your eyes so that I can introduce, not yet, so that I can introduce 2 smells for you to identify for me. Now, please understand, these scents are in no way harmful to you. They may just be strong so that you can smell them so we can assess.
Okay.
Are we okay with that?
It's fine.
Cover one side of your nose and tell me what you smell.
Methylated spirit.
Okay. All right. The patient was able to identify methylated spirit. All right. Therefore, his olfactory nerve is cranial nerve number 1 is intact. We are now going on to cranial nerve number 2, which is the optic nerve. We are going to assess his visual acuity. So, in this case, I will ask you to come with me, but we have to go somewhere else to do this part of the exam. We normally ask the client to stand 20 feet away from our Snellen chart. Alright, we have approximated that this is the 20 feet. So, what I would like you to do, without squinting or bending forward, I would like you to cover one eye totally. Can you do that for me? Right, make sure the eye is totally covered. Right. And I would like you to read from the top down to the smallest line that you can see.
E, F, P, T, O, Z, P, D, C, L, P, E, D, P, E, C, R, D.
Okay. Can you repeat that again?
P, E, C, R, D.
Alright. Can you read the line above?
L, P, E, D.
We always put the distance first, so the patient has 20/40 vision in the right eye. Okay, can you cover the next eye now for me, please? And repeat the same instructions.
E, F, P, T, O, Z, P, D, C, L, P, E, D, P, E, C, F, D, E, D, F, C, Z, P, F, E, L, O, P, Z, D, D, E, F, D, E, F, O, C, T, E, C.
Okay, can you repeat that line again?
D, F, D, E, P, F, O, T, E, C.
Okay, so the patient has 25 vision in the left eye. Now we are going to assess cranial nerve 3, 4, and 6, which is the oculomotor, trochlear, and abducens. What you need for this is a pen light that will be shone into the patient's eye. You sit and you look at the patient, and you would normally darken your surroundings, right? And when you darken your surroundings, you put the light on here, and you bring the light around to the pupils. And you look for constriction of both pupils when the light is shone in one eye. So what the pupil that constricts with the light in the eye is direct constriction of the pupil. And the next pupil that constricts when the light is shone in this eye is called indirect or consensual pupillary reaction, right? That is for the oculomotor. What we also do is we do the accommodations. With the accommodation, I will say to the patient, look straight ahead and follow the object with your eyes only as I move it from far to near. As I move the object from far to near, ideally what we want is that the patient's irises and pupil converges as the object is brought closer. So when it is like this, the irises and pupils are looking straight ahead, but as we move forward, they're supposed to converge as the object is moved closer. What we also look at as well, when we shine the light at the bridge of the nose, we're looking to see if the light is reflected in the same place on both irises. That is called parallel alignment. What we also do is we do the 6 cardinal points of gaze. So sir, what I would like you to do is follow this object with your eyes only without moving your head.
Yes.
Okay? We are making an H. So patient had smooth symmetrical movement through the 6 cardinal points of gaze. That is the assessment for cranial nerve 3, 4, and 6. We now go to cranial nerve number 5, which is the trigeminal nerve. The trigeminal nerve has 2 aspects to it. There is the motor aspect and there is the sensory aspect. We are going to do the motor first. So sir, I am going to put my hands on you. Okay? You find the temporomandibular joint, and at the temporomandibular joint, you tell the patient to clench their teeth. Clench. As the patient clenches their teeth, you will feel a bulge in the cheek. That is the masseter muscle being activated. That is the motor aspect of the trigeminal nerve. So when the patient clenches their teeth and you get a bulge in the cheek, that is the masseter muscle. Therefore, that is functional. Now for the sensory aspect of the trigeminal nerve. So, in this case, I would ask you to take your mask off, please. Thank you. I am going to present on your hand, I am going to present 3 touches for you. After I have presented the 3 touches for you to know, I am then going to present those 3 touches to your face while you have your eyes closed. And I will ask you to tell me where you feel the touch and what touch you feel. Will that be okay?
That's fine.
Okay. So, okay. So this is light, this is dull, and this is sharp. Okay? Alright. So now I would like you to close your eyes. Like I said, tell me which touch you feel and where you felt it.
Light on my forehead. Light on the chin. Light on my right cheek. Light on my left cheek.
Okay, keep your eyes closed.
Sharp on my right cheek. Sharp on my chin. Sharp on my forehead. Dull on my left cheek.
Okay. So the patient was able to identify light touches and most of the sharp and dull touches and where he felt them. Therefore, the sensory aspect of the trigeminal nerve, right, cranial nerve number 5, is functional. We are now going on to cranial nerve number 7, which is the facial nerve. We are going to, normally for the facial nerve, we assess both a motor and a sensory aspect as well. The sensory aspect for the facial nerve is the taste test. We did not bring any items to the taste test. I will just explain it to you. What we normally do is we have 3 different tastes, which is salt, sweet, and sour. We do not let the patient see either of these. We would explain to the patient that they are not harmful in any way. And then we would ask their permission to ask them to close their eye and present each test on the tongue with a tongue depressor. Like I said, we must emphasize that they are not harmful to the patient in any way. And once the patient has identified the 3 scents, then the 3 tastes, then we know that the sensory aspect of facial nerve is intact. So now we're going to do the motor aspect. So sir, what I would like you to do, I would like you to frown, right, raise eyebrows, smile, show teeth, purse lips, puff cheek, all right? I would like you to close your eye and resist me trying to open it. All right. So patient was able to frown, raise eyebrows, show teeth, smile, puff cheek, and he had some difficulty keeping his eyes closed during the resistance part. But predominantly his facial nerve, the motor aspect of the facial nerve is intact. Right? Now we're moving on to cranial nerve number 8, which is the acoustic or vestibulocochlear, which is assessing his hearing. All right? The first thing we do is the whisper test. How we do this? I stand on one side of the patient, approximately 2 feet away from the patient. You can use your hand to assess. As I am standing on the left, I will ask the patient to take his right index finger and place it in his right ear and wiggle the index finger while I am going to now repeat a 2-syllable word, and I want you to tell me to repeat it if you heard it. Okay?
Ice cream.
Okay, next one, the next left ear now.
Repeat. Hot dog.
All right. So the patient was able to hear and repeat the both 2-syllable words. We are now going on to the Weber's test, where we will use our tuning fork. This is our tuning fork. We never hold the tuning fork here. We always hold it with the stem here. And we have to be very careful where we activate our tuning fork. We do not hit it on any random object to activate it. You can use your wrist to activate the tuning fork. What we will do is, this is, as I said, the Weber step. We're going to activate the tuning fork and present it on the patient's forehead, and we will ask him if he hears, and if he hears it equally in both ears. Okay? Are you hearing?
Yes, I'm hearing it.
Are you hearing it equally in both ears?
Yes, I am.
Okay. The patient was able to hear the tuning fork and to hear it equally in both ears. That is the Weber's test. We are now going on to the Renis Test, which is the test for the difference between air conduction and bone conduction. You have to have a watch that counts second, a second-hand watch, to assess this one, because we're going to compare how long he hears it while it is on bone, as opposed how long he hears the sound while it's in the air. So, sir, I'm going to activate the tuning fork, and I'm going to place this part here on your mastoid process, which is the bone directly behind your ear.
Okay.
Right? I want you to tell me if you're hearing it and when you stop hearing it.
Okay.
Soon as he says that he is hearing the sound, you're supposed to start counting the time from then until he says that he stopped hearing it. When he says that he stopped hearing it, we are going to bring it here now, and then we are supposed to count the time again from the beginning, from when if he's hearing it to when he stops hearing it. And then we will compare the two numbers. So we activate. Are you hearing it?
Yes.
Tell me when you stop hearing it.
Stop hearing.
Okay, we look at the time. Are you hearing it?
Yes.
Right, we check the time again. Tell me when you stop hearing it.
Stop hearing.
Okay. This shows us that if you look at your time when he says to stop, you will realize that air conduction is longer in time than bone conduction. Alright? That is the tree assessment of the cranial nerve number 8. Cranial nerve number 9. Alright, what we will normally do for cranial nerve number 9 is we will ask the patient to put his tongue out, and we will use the tongue depressor and pull down his tongue slightly so that we can see the uvula. When we can see the uvula, I wouldn't do the patient that right now, but when we can see the uvula, we will then say to the patient, can you say ah? Right? When the patient says ah, we're supposed to see the rise of the uvula. We must see the uvula rises. That will tell you that that nerve is functioning properly. Right? The one after that is cranial nerve number 10, the vagal nerve. Again, if somebody is unconscious and we stick anything down their throat, the vagal nerve will not be activated because the patient is unconscious. However, if the patient is conscious and we should stick something down his throat, then we will activate the gag reflex. And we want to activate the gag reflex because that's telling us that the cranial nerve number 10, the vagal nerve, is intact. If this patient is awake and we put something down his throat and the gag reflex is not activated, then that could suggest further investigation. But as the patient is awake, we're not going to attempt to activate his gag reflex. Another alternative is we can ask him to put his chin up and he can swallow for us. When he swallows, we can see the rise and fall of the trachea. And as we see the rise and fall of the trachea, we know that the vagal nerve is intact. Alright, so that's cranial nerve number 10. Cranial nerve number 11 is spinal accessory. Okay? I will stand behind the patient, place my hand on his shoulder and ask him to try. And can you shrug his shoulder, please? When he shrugs his shoulder, I will try to push down on his shoulder, and he's supposed to resist me pushing down on his shoulder. So resist. Alright, so I was unable to push down his shoulder. Therefore, cranial nerve number 11, spinal accessory, is functional. And the last one is hypoglossal, which is cranial nerve number 12, and this we assess tongue strength. Okay, so we will ask the patient to put his tongue against his cheek, and I will try pushing his tongue away, and he is to resist me accomplishing that. Next slide. Alright, patient was able to resist me pushing his tongue away. Therefore, his hypoglossal or cranial nerve number 12 is functional. That is the end of the cranial nerve. Now we are going to assess motor and cerebellar. So we'll ask the client to stand. So I am asking the patient to stand in order for us to assess motor and cerebellar. As the patient stands, he is able to weight bear, right? Without assistance, he does not lean forward or need support. His toes are pointing straight forward. Sir, I would like you to walk up to there and back, please. As he walks, we can see alternative arm swing, and his toes remains pointing outward. Okay. Right? Now, I would like you to do tandem walking. So you can follow me, sir. Right? I would like you to do tandem walking, which is you walk like this with your head up. So patient is able to tandem walk with no difficulty. I would now like you to walk on your toes and then on your heels. Patient is able to walk on toes and heels without difficulty. I would now like you to stand on one foot and hop. Next one. Patient is able to stand on one foot and hop, again with no difficulties. Now we are continuing our assessment of the coordination. So I'd like you to follow me. You put your hand out like this and you will touch your alternative index finger to your nose. Slowly at first. I would like you to go faster now. I would like you to close your eyes and continue that. Faster, faster. Alright? Patient, okay, you can stop now. Patient was able to keep eyes closed while he brings index finger to nose rapidly. Therefore, his coordination is intact. We are now going to do the Romberg's test, right? I am going to ask the patient to stand. As we can see, the patient is standing, feet slightly apart, looking ahead. He is not swaying. There's no sway. I'm now going to ask the patient to close his eye, and we are going to assess for any swaying. We would have the client close his eye for 20 seconds to assess for swaying. I'm standing like this. Some clients do suffer from vertigo and they can misbalance, and we want to make sure we can catch them and help them to the ground if this should happen. Close your eyes, please. Right? 20 seconds you normally stay. Patient has minimal sway. Right? So I'm now going to present some objects, some objects for you to feel, and again, as we did before, it is sharp and dull and light. But we're not going to do it on the body, right?
Okay.
So again, we want you to close your eyes and identify what you're feeling.
Light. Light on my throat. Light. Sharp. Dull. Sharp.
All right, patient was able to identify sharp, dull, and light. Okay? I want you to close your eyes again, sir, and tell me if you're feeling 1 point or 2 points.
Okay. 2. 2. 1. 1. 1. 2.
All right, this is expected in the palm of the hand where the patient has a lot of nerve endings. He was clearly able to identify the 2 points. However, as we move away from the palm of the hand and to the upper limbs, he was not able to identify the 2 points, even though 2 point was being introduced to him. All right, so close your eye again first. Yeah. Can you tell me the position of your fingers?
Up. Down. Up.
Right, so patient was able to identify the position of his fingers with his eyes closed. Okay, therefore the cerebellum is intact. We are going to assess the knee reflexes. What we do, we get the patient to sit like this with their legs hanging, because we want the patient to relax the knee. Do not control. I am in control of the knee now. So you relax the knee and you let it swing. We use the triangle part here. We use our fingers and we feel for the tendon. Right? We feel for the tendon and we would not get a big knee-jerk reaction. We might get a small reaction, but we try to get a reaction. The most important thing is finding the tendon to tap on to get that reflex. This can be very tricky and it's not always possible to get it all the time. Okay, so it's not always possible to get it. And that is the end of the central nervous system. Thank you very much, sir, for your kind assistance. All right? So far, I have seen nothing that would warrant me having to send you for any further evaluation.
Okay, great.
Your doctor will be informed, right?